Good day, everyone. I'm here to talk about the care plan for 2-year-old Caitlin Bergen. Caitlin has recently been diagnosed with cystic fibrosis. Cystic fibrosis is an ongoing hereditary disease that causes tenacious infections and inhibits the ability to breathe over one's lifetime, according to the Cystic Fibrosis Foundation. Caitlin has been diagnosed for the second time in the last 6 months with pneumonia. On assessment, her breath sounds were diminished, her breaths were higher than normal, shallow, and she had an elevated temperature. Her lab value for the sweat chloride test was 65 milliequivalents per liter, which is milliequivalents is the same thing as moles per liter. 65 is above the 60 um, line. According to the Davis's Comprehensive Manual of Laboratory and Diagnostic Tests with Nursing Implications, yes, this is above normal. Her weight is 20.7 pounds. She displays reduced subcutaneous tissue in her arms and legs, so there's a concern for absorption of nutrients. She's received nebulized aerosol, after which she had thick secretions, and she also received chest therapy. Dr. Copeland has started Caitlin on antibiotics. Caitlin's parents are presently separated, and she lives with her mother, Janice. They live in McHenry, which is more than an hour drive away from the hospital in Valley City. I will now lay out a care plan for Caitlin Bergen. This care plan includes different members of different disciplines, including Dr. Benjamin, who's Caitlin's pediatrician, Dr. Copeland, the Valley City Regional Hospital pediatrician, Virginia Anderson, the nurse at Regional Hospital, Rebecca Helgo, the respiratory therapist, social services, and a dietitian. Dr. Copeland has ordered pancreas enzymes and fat soluble vitamins, which are A, D, E, and K. The dosage of the pancreas enzymes are calculated by the patient's height and weight. There are also labs to check the levels of the fat soluble vitamins A, D, and E, and there's an INR lab to check the vitamin K levels. As Caitlin gets older, dietary counseling for parents and child should be in order. This is according to NAREG and others. Rebecca Helgo, the respiratory therapist, understands that Caitlin is too young for huff breaths, so the focus should be on keeping up with nebulized aerosol treatments and chest physiotherapy. Respiratory distress is a very real possibility with cystic fibrosis, so teaching both parents about giving aerosol treatments and teaching how to do chest physiotherapy can be done via telehealth and videos like the ones made by the Cystic Fibrosis Foundation. Since the pandemic, more facilities are working to get these appointments accomplished through telehealth, according to SPEAR in 2021. The respiratory therapist will do telehealth appointments for this case and is willing to do work after hours to accommodate Caitlin's parents if necessary at all. The Bergens have insurance, but there's a question of how much coverage is available since the policy is relatively new. Caitlin's parents are also separated. It is absolutely important that at least one parent is taught the necessary education, but both will be optimal. Internet speed notwithstanding, this should be possible. Since socioeconomic status is closely linked with cystic fibrosis patients with health disparities, according to Bailey and Ladors, social services can try to address any help that the family might need and be able to coordinate services. In addition, mental health should be a consideration for this family because of the strain that they can experience emotionally. Anxiety and depression are a concern for caregivers of cystic fibrosis patients, as reported by Shardonsky and others. Dr. Copeland can be reached by phone and text by other members of the team, if necessary, and time can be set aside for members of the team to converse with each other whenever prudent. The model I used for this was the Johns Hopkins Nursing Evidence-Based Practice Model. My PICO question was, in newly diagnosed cystic fibrosis patients, is it possible to provide adequate treatment using telehealth versus solely in-person appointments? Caitlin is 2 years old, newly diagnosed with CF. Her parents are separated. They don't live very close to the hospital. So face-to-face appointments cannot be the only medium or only way for them to get a back and forth with the doctor. The sources I use to inform this care plan are peer-reviewed and published within the last 5 years to establish credibility and relevance. The evidence I received from the Rural Health Information Hub was the most relevant because the care, the procedures, and therapies were all there before. The article makes a strong case that it is possible to get care to people, even in rural areas, via telehealth, especially today during a pandemic. My sources are peer-reviewed and chronologically relevant, and the websites are credible. In conclusion, the interdisciplinary approach to this case is necessary because of the diagnosis and how it manifests. There are many concerns, such as dietary, respiratory, social services, and so forth. To give Caitlin the best opportunity for positive outcomes, all disciplines should communicate and coordinate with each other. As reported by Rural Health Information Hub, telehealth can help healthcare systems, companies, and medical providers in opening up access to patients and increasing the level of medical care available. Using telehealth in rural areas can make up for shortfalls in areas such as appointment visits and specialty care. Communication, efficiency, and monitoring are improved vastly by telehealth. Thank you.